And I want to just say thank you to Dr. Sandeep and Dr. Vinay and their whole team, and it's wonderful to sort of meet up with old friends and make many new ones. Now, they've asked me to talk on ischemic preconditioning. However, I changed the name a little bit because you can't see that in isolation. So we're going to talk, I've changed it to myocardial conditioning rather than only ischemic preconditioning. Does it mean, and what does it mean to us in the operating theater? I have to acknowledge our co-workers, and especially the man there next to me, Dr. Kanyisu Khadebe, is very much doing a lot of research in this field in the animal lab. And what a privilege to stand next to all-time greats like Professor Karen Sliva, Sandrine Lecoeur, and Professor Lionel Opie, who are, it's a privilege to be associated with people like that and work in their lab. Now, for many years, the maintenance of a favorable myocardial oxygen supply-demand ratio has been the cornerstone of peri-op medicine myocardial protective strategies. Now, while this is still true, increasingly the evidence over the last 15, 20 years is indicating that anesthetists may have other ways of protecting the myocardium in the perioperative period. And in the recent years, the potential clinical application of ischemic and pharmacological preconditioning in the perioperative organ protection strategies has gained wide interest. But many of this is still not proven and needs more validation. Now, major determinants of an infarct size is the area of ischemia, the duration of ischemia, and then the amount of residual blood flow. Now, I'm going to quickly run through the pathophysiology, and forgive me if I leave you behind here because we only have 25 minutes and you can have a 5-day meeting on this topic. So I'm going to try and get through the pathophysiology quickly, but we cannot move on to the anesthetic side unless we understand the full spectrum of what we're dealing with. Now, we have to have a good idea of coronary steal. The major determinants of the infarct size, therefore, is the area of ischemia, how long it continues for, and then the residual blood flow to the risk area afterwards, the collaterals during the ischemic time. And then minor things are hemodynamics and heart rate, some things that we can manipulate much easier, the oxygen demand and supply. And don't forget how this whole steal phenomenon works. It's well described. Now, the largest fraction of cardiomyocyte death is associated with reperfusion. So a lot of the damage is done once blood flow is restored within the initial minutes. So there are lots of things that happen, the rupture of cell membrane and due to the mechanisms organizing in the myocyte rather than vascular or in the blood. So this can be prevented or decreased by interventions that can be applied, but there is no magic bullet yet. Now this, I am very grateful I got from Dr. Lecoeur, Professor Sandrine Lecoeur, and Dr. Delig Yellon has done this work, where it's actually, what it explains is that if you have ischemia and you do not have reperfusion, you get a lot of damage. Basically, the heart can just live for so long without blood supply. If you then reperfuse, say the clot breaks down in the coronary artery and blood flow is restored, you get some part of that viable tissue is recovered and can survive. But reperfusion in itself can cause damage. In itself, it brings bad things to the heart, and therefore what is saving you can also cause the damage. But paradoxically then, although the myocardial reperfusion is essential for myocardial salvage, it comes at a price. And as it can in itself induce myocardial injury and myocardial death, this is called reperfusion injury. Now we can manipulate this green bit with hopefully pharmacological techniques, but definitely this is where ischemic and remote pre and post conditioning comes in. So we can achieve the little bit we cannot do. The last red bit we cannot do much about, but the rest we can if we restore blood flow. I'm not going to go into detail, but it's all about protein kinase activation and these reactive oxygen species, which this causes the damage. And these, we must remember that aerobic organisms like humans we all utilize molecular oxygen as a terminal electron acceptor to enable the metabolism of organic carbon for providing our energy. Now with one molecule of glucose, if we think of the glycolysis pathway, Embden-Meyerhof, then we produce 38 ATPs, and we produce water and CO2. And there is a normal process of a little part of that is channeled via other pathways where all these oxygen radicals are being produced. This is normal protective strategy for our body and for the cells. But almost like the anticoagulation system, if it gets out of hand, if it's out of balance, and we are without oxygen, anaerobic in other words, then more is channeled down this pathway, and we produce all these oxygen radicals and superoxide and so on. And those can cause damage if there is an imbalance of that. Now, oxidative stress, it causes a change in pH and excess in calcium and lots of inflammatory changes intracellular. But the important one word we must remember here is MPTP. Now they talk about the mitochondrial permeability transition pore. It's basically a channel which opens, and all of these bad elements then stream inside the cell and causes lethal reperfusion injury. This is how it works. So the opening of this channel is what has been believed over the past 20 years or 10 years we can manipulate and prevent. So all this leads to protein kinase activation with the production of reactive oxygen species and nitrogen species, and the phosphorylation of many substrates, activating these injury. And this has been very well proven, and there are specific groups in the world, you can almost point them, clever people sitting in certain units thinking and dealing with this topic. Now, it has several different ways of presenting itself, reperfusion injury. We know in the clinical setting, arrhythmias, myocardial stunning when the heart can't contract very well, microvascular obstruction and myocardial hemorrhage, and then this lethal injury where you cannot restore function afterwards. So before we move on and look at the preconditioning and conditioning, we have to understand or just revisit the definitions of stunning and hibernation. As described by Braunwald and Kloner, stunning is a post-ischemic myocardial dysfunction. In other words, blood flow has been restored to that specific area of the myocardium. This is often, you see it with unstable angina, or when what we see is in the operating theater when a cross clamp goes on and it comes off. Then the heart is stunned. And we've always all been in a situation where you have to use a little bit of inotropes to override this. Inotropic support can override stunning. Then Dr. Ramtula has described hibernation as an entity where they talk about the smart heart. It's a state of persistent, impaired myocardial dysfunction. So the heart protects itself from injury by not working so hard, by restraining itself. And this was described, has also been described over the years, and people understand it's these two principles we need to understand. When you talk to a bunch of cardiologists, they have a different understanding from cardiac surgeons, from anesthetists, to what conditioning and how conditioning works and how we can protect. So in surgery, they target the ischemic time, so you can do something, you know when the cross clamp is going to go on and comes off. If you think of cardiologists, PCI for instance, the coronary is occluded by the time the cardiologist receives it. So he targets the reperfusion time. That's where they can make a difference. And in anesthesia, this is very much what we can do. We can target with pharmacological, the reperfusion, with pharmacological ways, the reperfusion injury. Now, I'm not going to go into surgical myocardial protection, but it's well described in a total topic in itself, cardioplegia and how it developed. But at the moment, we all know about warm and cold, blood cardioplegia, crystalloid, antegrade, retrograde, and then the important thing is the diastolic cardiac arrest, so a flaccid heart. And they keep the heart empty because we try and avoid the whole Laplace idea where the wall tension is a strong consumer of oxygen, a high wall tension. Therefore, the surgeons don't like to see a big distended heart. And we know that is what you see when you have a cardiac arrest, while actually in the operating theater, a heart on bypass can fibrillate for how long and still function when you defib it. So all of these concepts have now evolved over the past 30 years. So they talk about, and the terminology is important. People talk about preconditioning, post-conditioning, remote conditioning, delayed conditioning. And then there are many novel human applications. And just to sort of give an example how these things work, the whole idea that there are brief episodes of ischemia and then reperfusion of the heart without causing damage can protect against subsequent myocardial infarction. So if you therefore can give remote preconditioning or well, for that matter, preconditioning before the time but the point is, nobody knows exactly for how long and how many times. And we've all seen surgeons using cross-clamp fibrillation as myocardial protection. I could never understand it. Why do you want to sort of half strangle the heart before you sort of do it finally for a long period of time? But it seems like something happens on a cellular, molecular level where in the heart it develops almost like a protective way that when you then have a longer cross-clamp period, it is protected and there is not much of long-term damage. Now, people also talk reperfusion afterwards because that's when the damage happens, and you find surgeons will clamp, release. There was a time when I was working with a surgeon, clamp, release, clamp, release. It's not something that I liked. I always preferred the cardioplegia way. However, it seemed to have also worked. So, the enhanced tolerance to prolonged ischemia, which follows brief periods of transient ischemia, that's what preconditioning is. And it's a phenomenon whereby the exposure to a physical or a pharmacological stimulus reduces subsequent injury from ischemia. And it has been well proven, well shown in animal studies, in the animal lab, that this is the most powerful endogenous protection available. But it's very difficult at this stage. We have not managed to extrapolate that into the clinical scenario. There are two phases of preconditioning. It's a major discovery in the early 1990s where they say the early phase, which occurred within few minutes from exposure to the initial ischemic stimulus, lasted 2 to 4 hours, that protective phase. And then there's a late protective phase which was developing much slower, over 12 to 24 hours, and it lasted longer, 3 to 4 days. Early phase, very effective in limiting lethal ischemia reperfusion injury, but it does not protect against myocardial stunning. The late phase protects against stunning and infarct, but is less powerful than the early phase, and this has been well described. Now, I don't know whether any of you have ever spoken to somebody who has discovered a pathway, but Professor Sandrine Lecoeur, and it's what a privilege, young lady, and she came up with this safe pathway after Hausenloy and Yellen described the risk pathway. These are just people trying to explain how this conditioning works. Now, enough of that. There's no point in going to, because we want to get to the real stuff in anesthesia. Now, the remote preconditioning came on board more recently. And it's a phenomenon whereby inducing ischemia distant to the myocardium provides myocardial protection after reperfusion of the remote tissue. So in other words, a blood pressure cuff around the arm, and then, by the way, the heart will be protected. Very strange concept, but it seems like this was a theory and people were studying that. And the first one, randomized controlled trial of intraoperative remote ischemic preconditioning in humans, was performed in children undergoing congenital defect repairs. And this study demonstrated a reduced postoperative troponin I. Now remember, they only had 37 children, so how underpowered can that be? It showed a reduced trop I and less inotropic support required and a lower airway resistance in the treated patients. So they tried their procedure and they seemed to find that there are certain markers that look better after the operation, but still it is not a clear confirmation. Now, then after that, proof of concept trial, this I can say we are privileged to have. No, she's not on there. Sorry, this one came from a different unit where they looked at the animal lab, in the animal lab. So in the rabbit heart, people have seem to have shown that this does not work so. So you find conflicting groups. They have showed it doesn't work. Other people show it works. So it's a bit controversial. And they show that it does not protect against ischemia reperfusion injury, the whole ischemic remote conditioning. And then this, again, they from Hausenloy, 45 adults undergoing CABG, receiving cold blood cardioplegia, and they have their sort of whole protocol that they go through, on-off, cuff inflated, and the idea from a remote. And then only 45 patients again. So the remote upper limb ischemic preconditioning in these adults undergoing CABG, they showed a reduced postoperative troponin I levels. Then again another one, and I'm just quoting a few because there's been vast research done on this and publications on this. And this group showed remote ischemic preconditioning hypoxic neonates undergoing cardiopulmonary bypass surgery does not provide myocardial, renal, or neuronal protection. So, contradiction. And then, recent publication from the Hoysch team, Gerd Hoysch from Essen, about post-operative outcome and remote ischemic preconditioning in patients undergoing elective CABG, published in the Lancet 2013, has major flaws. And one of them is the control group had a mortality. They said it provides, a remote ischemic preconditioning provides protection. But their control group had a mortality rate of, these are CABG patients, of 6.9%, which we know is very, very high. So why would they have this positive outcome? So after that, the ERICA trial, and we know the ERICA trial is Gudrun Kunst was presenting here. She should have been given this lecture, but she was very much part of it. And this was a proof of concept trial from London, and it showed that remote ischemic preconditioning does not really protect the myocardium in addition to volatile preconditioning. So all inflammatory markers that we measured were similar in the volatile-only group if you compare to the volatile plus remote ischemic preconditioning. So really not coming up with the answer, and this has been confirmed afterwards. Now, in Sweden, they've tried to show in the ambulance, starting, on remote conditioning in the arm, the paramedics put the cuff on, and again, they've looked at markers and they found that there's an infarct size that is smaller at 30 days when you look at SPECT scanning or imaging. Post-conditioning, a phenomenon where exposure to a physical and pharmacological stimulus after ischemic insult reduces subsequent injury from that ischemic insult. And again, we're running out of time here, so I'm not going to spend too much time on the mechanism, how it works. But again, the pathway, safe and risk has been followed. The idea is if you come up, this sounds too good to be true, that after an injury, you can suddenly start to protect it. But people have tried and showed that there are also conditions which attenuate post-conditioning, and medications like, this is now the interesting bit, adenosine, nitroglycerine, ACE inhibitors, statins, opioids, we're using those, clopidogrel, and so on, may attenuate post-conditioning. Now we get to pharmacological conditioning, and if you may give me another 5 minutes or so, then I'll try and speed up. But the problem with this is, the whole idea of pharmacological or anesthetic induced preconditioning or post-conditioning, we don't know the optimal dose and the timing of administration. I mean, we all start our anesthetic before. And then, but how much must your MAC be to protect the heart? So this would be the holy grail. If we could give a silver bullet and it protects the heart. So cyclosporin, it's not a drug we're dealing with, but it's been shown to prevent the opening of the MPTP, that pore, at the time of reperfusion. And it therefore has got some sort of protection effect, but we don't use cyclosporin. And it may decrease the infarct size quite a bit. And people have shown different levels of CK release, or a lower level if you use cyclosporin. And then I recently spoke to Stefan de Hert, and I said, why are you not working on ischemic conditioning anymore, or preconditioning? And he basically said, because it's out of fashion. I'm not using it. There's no point in concentrating. There are so many high-end groups. It's sort of got out of fashion. And this is why we haven't really, people have all tried this very good idea, but not really got to a clear answer, because we're dealing with such heterogeneous groups of patients. So people have shown, and the one which is quite clear in animal lab and has been very well proven is inhalation anesthetic agents. So shown first with halothane, and now it seems like all the inhalation agents has got some sort of cardioprotective effect, independent of its effect on the myocardial oxygen balance. And many names and many people have proved that, and also come up with meta-analyses afterwards, where this has been. Paul Miles, for instance, has shown, and he looked at 27 clinical trials, so many patients, cabbage or only, and showed that there may be less troponin T release and less post-op myocardial ischemia, the duration of ventilation and in-hospital stay and mortality has been reduced. And this is what his meta-analysis showed, and they published that in 2006. Now, other volatile agents undergoing myocardial surgery, there's been critical reviews, and in the lab it's been very well shown. Paul Pagel and David Voltier from Milwaukee, one of the big groups working on this, and they've shown that, he explained very nicely in this review, that in the animal lab, yes, it's very difficult to translate therefore into the clinical practice. And so far, the question whether volatile agents have an impact on clinical outcome in cardiac surgery, it still remains open. I mean, it points in that direction. We think it works, but we have not really proven it. Noble gases, xenon, and so on, it's not something we use every day, but people have shown that it may be. A growing body of experimental evidence indicates that brief intermittent exposure to a noble gas may protect against irreversible ischemic injury. Propofol, now that's an interesting one. Propofol, it seems like propofol may take away. Now, in itself, it's supposed to be an oxygen radical scavenger. But if you give it together with inhalation agent, it seems to blunt the protective effect of the inhalation and inhalational agent, which is not really what we want. So, remote ischemic preconditioning during isoflurane, but not during propofol anesthesia, decreased myocardial damage. This is what this group has shown from Sweden. So many co-workers, many people working together on this topic. It seems like alcohol protects. So all the people who enjoyed themselves last night, chronic alcohol use does seem to precondition. Opioids seem to have some sort of effect. Opioids like morphine, fentanyl, it's got some sort of cardioprotective effect by itself, as well as enhancing the effect of ischemic preconditioning. But compared to the other opioids, it seems like morphine is a very potent one. So morphine it works on more receptors, not so pure, and therefore it seems to do better. So I have to wrap up. Yeah, this one from Gudrun came 2 years ago, where she very nicely explained that we have more questions than answers about this topic. And it's all about the MPTP, that pore, the opening of the myocardial KATPA channels, G protein coupling receptor activity and cellular kinases. So these are things we can't see, and working really on a cellular level. And the reactive oxygen species production. But our problem is still, what is the optimal dose of what we're using, of any specific drug? What is the magic bullet, and what is the optimal timing? So there is no answer to that. So to summarize, remote preconditioning, the whole cuff on-off is simple, is non-invasive, and it's safe. So people have tried it, they're using it. With limb ischemia successfully been performed for CABG, elective and primary PCI. However, the exact, whether it works in humans, still have to be proven. So it may protect. And therefore, the whole idea is very sort of attractive to think that you can start this when you pick up a patient in an ambulance. The whole cyclosporin effect has been very well shown in the animal lab. We know inhalation agents, all of these, more or less the same, has a protective effect, certainly in experimental evidence. We believe it may work in humans. Opioids, especially morphine, may have an effect. Propofol may just interfere. So these propofol infusions going after bypass and back to the, maybe that's something we must just think about. And the whole idea of the sulfonylureas and oral anti-diabetes treatment, they must be stopped. We know that that is interfering with the whole preconditioning or ischemic conditioning. Insulin, it may be beneficial, and as they say, larger series is needed to show. I'm going to stop there and invite you to the celebration, the end of the year, and the end may be benefit in the end, as in the end larger series.